Hello, my name is Dr. Bruce Strober. I am a dermatologist at Central Connecticut Dermatology and a clinical professor of dermatology at Yale University School of Medicine. Today, I am excited to share data from the B-Radiant clinical trial, a phase 3b randomized, double-blind, active comparator controlled study of bimekizumab versus secukinumab for the treatment of moderate to severe plaque psoriasis. Bimekizumab is currently being investigated for the treatment of moderate to severe active plaque psoriasis. The safety and efficacy have not been established, and bimekizumab is not approved by any health authority worldwide. Bimekizumab is a monoclonal antibody designed to selectively inhibit IL-17F in addition to IL-17A, two cytokines that have overlapping biology and that are pivotal drivers of inflammation in psoriasis. IL-17A is more potent, but IL-17F is more abundant in psoriatic skin lesions and can drive inflammation independently of IL-17A. Increasing evidence suggests that direct inhibition of IL-17F in addition to IL-17A may be a more effective mechanism than targeting IL-17A alone. Secukinumab is a widely used biologic that selectively neutralizes IL-17A only, whereas the design of bimekizumab allows neutralization of IL-17A homodimers, IL-17F homodimers, and IL-17A, IL-17F heterodimers. The objectives of the B-Radiant clinical trial were to compare the efficacy and safety of bimekizumab versus secukinumab for patients with moderate to severe plaque psoriasis. In this 48-week trial, 743 patients with moderate to severe plaque psoriasis were randomized to receive either 320 milligrams of bimekizumab every 4 weeks or 300 milligrams of secukinumab every 4 weeks, dosed according to product labeling for 48 weeks. Then, at week 16, patients receiving bimekizumab were re-randomized 1:2 to receive a maintenance dose of 320 milligrams of bimekizumab every 4 weeks or every 8 weeks through week 48. The primary endpoint in this study was the percentage of patients who achieved a 100% improvement from baseline in their psoriasis area and severity index score, or PASI 100, at week 16. Two co-secondary endpoints also assessed during the study were the percentage of patients who achieved a 75% improvement from baseline in their PASI score, or PASI 75, at week 4, and the percentage of patients who achieved PASI 100 at week 48. The patients enrolled in the study were representative of a population with moderate to severe plaque psoriasis and included approximately 33% of patients who had prior experience with biologic therapies. The primary endpoint was PASI 100 at week 16. 61.7% of all patients treated with bimekizumab reached this endpoint, which is a significantly higher proportion compared to the 48.9% of patients receiving secukinumab. Similarly, during the maintenance phase, 67% of patients treated with bimekizumab every 4 weeks or every 8 weeks achieved PASI 100 at week 48, compared to the 46.2% of patients treated with secukinumab. Compared to patients receiving secukinumab, more patients receiving doses of bimekizumab every 4 weeks or every 8 weeks sustained a PASI 100 response over 48 weeks. These data demonstrate both the superiority of bimekizumab over secukinumab in complete skin clearance, PASI 100 at week 16, and the durability of this response over 48 weeks. A similar pattern was observed in PASI 90 response at week 16, as 85.5% of patients receiving bimekizumab every 4 weeks achieved PASI 90 at week 16, compared to the 74.3% of patients receiving secukinumab. Likewise, 83.6% of patients treated with bimekizumab every 4 weeks or every 8 weeks during the maintenance phase achieved PASI 90 at week 48, compared to the 70.5% of patients treated with secukinumab. Consistent with these results, a higher proportion of patients treated with bimekizumab every 4 weeks or every 8 weeks sustained PASI 90 over 48 weeks compared to the patients treated with secukinumab. Similar results were also observed in the proportion of patients achieving complete skin clearance or almost complete skin clearance, an IGA 0/1 response. Rapidity of response was also assessed by evaluating PASI 75 and PASI 90 responses at week 4. 71% of patients receiving bimekizumab achieved PASI 75 at week 4, a significantly higher proportion compared to the 47.3% of patients receiving secukinumab. Likewise, 35.9% of patients treated with bimekizumab achieved PASI 90 compared to the 17.6% of patients treated with secukinumab at week 4. These data demonstrate that a greater proportion of patients treated with bimekizumab have a faster and deeper level of response compared to patients treated with secukinumab. The most common treatment-emergent adverse events, or TEAEs, that occurred in the course of the 48-week study were upper respiratory tract infections, oral candidiasis, and urinary tract infections. Rates of serious infections and latent tuberculosis were comparable between patients treated with bimekizumab and patients treated with secukinumab. The vast majority of oral candidiasis cases were localized, mild to moderate infections, which did not result in study discontinuation, and were able to be managed with standard antifungal therapy. Incidences of suicidal ideation and behavior, malignancies, serious hypersensitivity reactions, major adverse cardiovascular events, and elevated liver enzymes were comparably low in patients treated with bimekizumab and those treated with secukinumab. In summary, the B-RADIANT clinical trial was the first phase 3 head-to-head study comparing the efficacy of bimekizumab, a dual inhibitor of IL-17F, in addition to IL-17A, to secukinumab, an IL-17A inhibitor. Compared to patients treated with secukinumab, bimekizumab-treated patients achieved superior levels of complete skin clearance, a more rapid response, and greater durability of response over 48 weeks. The incidence of most TEAEs, severe TEAEs, and study discontinuations were comparable between the treatment groups. However, the incidence of oral candidiasis was elevated in bimekizumab-treated patients. The vast majority of these oral candidiasis cases were mild to moderate, responded to standard antifungal therapy, and did not lead to discontinuation. Thank you for joining us today. I hope you found this video educational and informative.